Good evening. At the outset, let me thank the entire executive of the Association of Surgeons of India for the honor bestowed on me to do this live webinar on interventions in acute pancreatitis. My thanks to Dr. Birappa, Head of the Department of Surgical Gastroenterology at Nizam's Institute of Medical Sciences, Hyderabad, who has agreed to chair the session. And my special thanks to Dr. G V Rao, who has been coordinating this digital CME program. In the next 30 to 40 minutes, I will be talking about the interventions in acute pancreatitis in 2020, and we just see what are the evidence that we have in acute pancreatitis, what are the various interventions that we do, and what are the practices that are practiced across the globe, what are the compliances to this, and what should be practiced in different parts of the world and different parts of the country based on the expertise and equipment that you have in different parts of the world. Acute pancreatitis in 2020, the management options are variable and different specialties are involved in the management of acute pancreatitis. Acute pancreatitis is one of the most commonest admissions to the ICU and critical care and is associated with significant morbidity and mortality. Most of the literature is focused on drainage and debridement techniques and technology with improved morbidity and mortality. Surprisingly, there is little that is talked about critical care. There seems to be some disconnect between critical specialties which are responsible for the continued morbidity and mortality, and there is a lot of importance that is stressed on critical care in the management of patients with acute pancreatitis. Now, the 8 fundamental steps that are revised according to this pancreat acronym, actually most of the postgraduates can remember this. Actually, we talk about P for perfusion, A for analgesia, N for nutrition, C for clinical classification, R for the radiological imaging, Ercp interventions during acute pancreatitis, A for antibiotic usage in acute pancreatitis, and S for surgery, interventional radiology or endoscopic procedures that are done. But we have to remember that the backdrop of this, the critical care is the most important thing in this entire phase the patient goes through in acute pancreatitis. Now let us just go through some of the fundamental steps of this management of acute pancreatitis. The perfusion goal, we should be able to reach a CVP of 12 to 15 millimeters of mercury and an urinary output of 0.5 to 1 ml per kg per hour, and an IVC collapse index of greater than 48%. So this is the perfusion goal we should be able to achieve. Analgesia, it's usually multi-modal, systemic or combined pharmacological agents, and sometimes we'll be using epidural block to treat these patients who have severe pain during this period of acute pancreatitis. Nutrition is very, very important. Enteral, there is a lot of data to show that enteral feeding is the best. Enteral feeding in gastric or post-gastric pyloric position is absolutely very essential by placement of an NJ tube or an nasojejunal tube. Parenteral nutrition works best in difficult cases to achieve the individual total caloric value. Whenever we are not able to maintain this by enteral nutrition, we can supplement this with parenteral nutrition. Clinically, these patients are classified as mild, moderate and severe pancreatitis according to the revised Atlanta criteria. Most of you are aware of this. The CT scan is best performed on the 4th day for prognosis and to modify the treatment protocols, modify the management protocols during this period, management of acute pancreatitis. Ercp is one of the modalities to treat any emergencies during acute pancreatitis, especially gallstone pancreatitis, patient with cholangitis, unpredicted clinical course and ascending jaundice. These are the indications for Ercp in patients with acute pancreatitis. The only rationale for using antibiotics is documented pancreatic infection. There is some role to show that antibiotics have some role in extra pancreatic infection, but for pancreatic infection, the only rationale is whenever we have a documented evidence of pancreatic infection, we can start using antibiotics. Now, surgery, interventional radiology and endoscopic are the 3 modalities that are used to intervene for any consequences or the sequelae of acute pancreatitis in these patients. Now, the dogma is represented by 3 Ds. You delay the treatment as much as possible, you drain the infected fluid and debride. The preferred method is as far as possible minimally invasive procedure, which allows for gradually more invasive procedures when the previous treatment fails. So in 2020, it is always essential that we follow a sequence, a step-up approach from minimally invasive to maximally invasive procedures. To summarize this, I'll just show you in a cartoon just to show we have to delay as much as possible, and you drain the infected fluid, debride as much as possible, and I'll add 2 more Ds to this. If you deviate from any of these protocols, invariably you end up with increased mortality in these patients. So these 5 Ds seem to be very, very essential in the entire course during which the patient is admitted in the hospital from the time of acute pancreatitis to any interventions that we do. Now we have this acute pancreatitis. Basically it is interstitial edematous pancreatitis. Less than 4 weeks, these patients, they are called as acute peripancreatic fluid collection, and once it crosses 4 weeks, these interstitial edematous pancreatitis end up as pancreatic pseudocysts. Now we have this necrotizing pancreatitis on the other side. Less than 4 weeks, they are called as acute necrotic collections, and more than 4 weeks, they are called as walled-off pancreatic necrosis. Just to show you the cartoon depiction of the same, the evolution of peripancreatic fluid collections. Acute pancreatitis, now this is what pancreatic ductal disruption, and then we have the necrotizing pancreatitis. After 4 weeks, this becomes a pseudocyst, and this becomes pancreatic necrosis, which is called as walled-off pancreatic necrosis in current day clinical practice. Now, Todd Barron is a gastroenterologist, endoscopist par excellence. He is the person who created this term called as walled-off pancreatic necrosis or walled-off necrosis. This is basically an endoscopic definition. So basically what it means is whenever there is fluid, it is called as pseudocyst, and whenever there is some amount of debris, it is called as walled-off pancreatic necrosis. So in 2020, if you see, most of the endoscopic interventions or most of the interventions seem to be based on endoscopic ultrasound, and endoscopic ultrasound is very, very highly sensitive to detect even small amount of debris that we see. And so the conversion rate is very, very high. So what I mean to say is some of the pseudocysts that we see on CT scan could be endoscopic ultrasound wands. So most of the wands in endotherapy series are CT pseudocysts, because current endoscopic practice is purely based on endoscopic ultrasound. So it is likely that some of the CT pseudocysts are treated as endoscopic ultrasound walled-off necrosis. Now, in current day clinical practice, the question that is repeatedly asked is, are there no non-wands? In the sense, what I'm saying is, what about non-walled-off pancreatic necrosis? See, we have this necrosis that extends into the paracolic gutters, the right and the left paracolic gutters. Sometimes it extends into the mesentery, pelvis, and it can always extend into the mediastinum. Now, for these, the term initially we used to use a term called pancreatic necrosis. Now, because with the advent of walled-off necrosis, this pancreatic necrosis term seems to be becoming obsolete, but the term that is used for this extended necrosis is extended walled-off pancreatic necrosis. So very clear, walled-off necrosis in relation to the stomach of duodenum, and we have extended walled-off pancreatic necrosis that is beyond the stomach and duodenum in the paracolic gutters, in the pelvis, or in the mediastinum. We have to understand that almost about 3 decades, more than 2 centuries now, all the management concepts seem to have evolved from surgery. All the peripancreatic fluid collection, the management concepts have evolved from surgery, and surgery has been the gold standard for management of peripancreatic fluid collections across the globe. Now let us look at some of the principles that evolved over surgery. Now we all know that once the patient has got infected pancreatic necrosis, the mortality goes up. So we have a patient with infected pancreatic necrosis, the mortality is about 30%. Whenever we have infected pancreatic necrosis with septic complications, the mortality goes to 80%. And if you have infected pancreatic necrosis with multi-organ failure and you still continue to treat this patient conservatively, the mortality is almost 100%. Now, when do we intervene in this patient with peripancreatic fluid collections? There is a lot of surgical data to show that if you intervene less than 2 weeks, the mortality is very high. So there is very, very clear evidence that you should not intervene in early patients, in these patients with acute pancreatitis. And there's a beautiful prospective randomized control trial which is published, which shows that if you go in early and intervene in this patient, the mortality is very high, 56% versus 27% when there is delayed intervention. Now, it is ideal that you delay this intervention for at least 4 weeks from the onset of acute pancreatitis, basically because There should be a proper demarcation of pancreatic and peripancreatic necrosis. This decreases the risk of bleeding, whichever type of intervention that we do, and it minimizes surgical related lot of vital tissue whenever we do this debridement. The therapeutic approach should be that drain as much of infected fluid as possible, and you should be able to mechanically remove as much of necrotic tissue as possible. Now, there is a component called as sterile necrosis. Sterile necrosis without organ failure. Now, some of these patients can be managed conservatively. You have no infection, no organ failure, this patient can be managed conservatively. But sterile necrosis with organ failure, these have poor outcome with both surgical and conservative treatment. Now, a select group of these patients with sterile necrosis may require intervention. What are the indications for walled-off pancreatic necrosis in 2020? Infection, organ failure, intractable pain, gastric outlet obstruction, and disconnected duct are the indications for intervention in walled-off pancreatic necrosis. So we all know that surgery has been the gold standard across the globe. Now in 2020, we have this paper which was published, a step-up approach of the Panther Trial, which was published in NEJM, which showed that a step-up approach, in the sense you put a pigtail catheter, drain it, and subsequently you do a small incision, and then you do a video-assisted necrosectomy. So this step-up approach, which was published in 2010 in NEJM, you can see this is the Panther Trial, and this is a very small series that have compared open necrosectomy with the step-up approach, and they have concluded that step-up approach is absolutely superior to conventional open necrosectomy. Now this paper that published in 2010 seems to have changed the entire management of patients with acute pancreatitis, and people have switched over from open necrosectomy to step-up approach. Now this, though it's a small group of patients, now they have published this in 2019, they have published the long-term follow-up of these patients, and they continue to state that there is no difference in recurrent or chronic pancreatitis in patients. These patients did well. There is less trend towards endocrine insufficiency, and the quality of life, of course, are less in these patients who are undergoing a step-up approach. Now, but this, as far as compliance is concerned, most of the centers seem to have switched over to this. But if you see this beautiful meta-analysis, which is published in 2019, actually very recently we have this meta-analysis that is published, which shows that though there is a lot of talk about this step-up approach, with lot of evidence that I'll show you subsequently, it is shown that both endoscopic interventions and surgical interventions, be it open or minimally invasive, seem to be preferable over percutaneous intervention. This is a meta-analysis. This has just recently come in to show that this percutaneous approach is a valid approach, but it has to be in select group of patients. It is not that it can be the only treatment option that we offer for these patients with walled-off pancreatic necrosis. So this Panther trial, which came in NGM, which was a step-up approach by the radiologists and the surgeons together, this has created endoscopist attention because the endoscopist started doing this procedure, and in addition to the interventional radiology procedures, umpteen number of centers across the globe started becoming very aggressive endoscopically, and endoscopic has become one of the modalities to treat these patients with walled-off pancreatic necrosis. So we have surgery, we have interventional radiology, we have endoscopy. So in 2020, walled-off pancreatic necrosis either can be treated by interventional radiology, endoscopy, or surgery. And when it comes to surgery, it can be either open, laparoscopy, or retroperitoneal scope. Let us see all these interventions that we do in 2020 and see the pros and cons of each of these interventions and see what is the best practices that can be practiced in 2020. Now initially endoscopy, it used to be a direct endoscopic necrosectomy. They used to dilate the thing and then between the gastric wall and the wall-off necrosis, and subsequently do a necrosectomy. Now this unfortunately had a significant 6% mortality and lot of complications associated with this, and there are complications like this bleeding which can occur, which can sometimes be controlled with endoscopy, and sometimes when there is not good approximation between the stomach and the wall-off necrosis, you can see that both the stomach and the wall-off necrosis get separated. And then these are the patients we present with massive pneumoperitoneum and require some sort of surgical intervention. And these patients can have infection or sometimes the possibility of an air embolism. So what has happened was, because of these limitations of the practice, these newer stents came into clinical practice. These are called as lumen opposing metallic stents that have come into clinical practice. Various stents are available in clinical practice. Nagi stent is made from India, Axio stent and the Spaxer stent. Now, and there is a lot of evidence that has come in after the introduction of this lumen opposing stents. This basically opposes the walled-off necrosis wall and the posterior gastric wall, and there's a lot of evidence to show that these lumen opposing stents are superior to the original stent that we used to use and the plastic stent that were used in initial practice. So in the current day clinical practice, endoscopic intervention of walled-off necrosis is usually done with lumen opposing metallic stents, and there is a lot of data to show. This is the paper published from our own side, which showed that a lot of these peripancreatic fluid collections, be it pseudocysts or walled-off necrosis, can be very effectively treated using this lumen opposing metal stents. So as in today, till 2019 or early 2020, there is a lot of evidence to show that lumen opposing stents are the best stents to use to treat walled-off necrosis. But there is one meta-analysis which has just come in. I don't know how much of value we have to add to this, but it is shown this meta-analysis shows that there is no difference in technical success or adverse event rates of drainage based on peripancreatic fluid collection type or the stent used. So we just have to wait for some more data to see whether the original plastic stents can still be used endoscopically to treat this patient with walled-off pancreatic necrosis, or it has to be only lumen opposing stent. But as in today, all walled-off pancreatic necrosis treated endoscopically are treated using a lumen opposing metallic stent. Now let us see at the data that we have that compares the endoscopy and surgery. Now this is the Dutch pancreatitis study that showed, which compared endoscopic transgastric versus surgical necrosectomy. Let us be very clear. The endoscopic transgastric is basically walled-off necrosis which are in relation to the stomach or the duodenum, and surgical necrosectomy is all these patients which have got this extension to the paracolic area, pelvis, or into the mediastinum. And this they showed that the complication rate, the fistula rate is slightly higher in patients undergoing surgical group, obviously basically because these are the patients who are being treated with drains. Obviously the pancreatic fistula rate is higher, and these are the patients who have got extension into paracolic gutters and mediastinum. But this paper shows that endoscopic intervention can be done, and this is the one which shows that transgastric intervention, walled-off necrosis in relation to stomach and duodenum can be effectively treated endoscopically. And again, this Tension trial which came in, which compared endoscopy with surgical step-up approach, again which showed there is some superiority of endoscopic approach in form of post-op pancreatic fistula, hospital stay, and the cost, basically again because you're comparing walled-off necrosis in relation to stomach, which can be very effectively drained into the stomach, versus extra pancreatic extensions into paracolic gutters, mediastinum, or into the pelvis. And there is editorials, papers that are coming in literature to show that endoscopic intervention is one of the modalities to treat this patient of walled-off pancreatic necrosis. But there are a lot of limitations on endoscopy side, especially there is a myth. People believe that whenever we do this gastric dilatation, the gastric juice goes into the retroperitoneum and aids in the clearance of necrosum. And various agents are used, hydrogen peroxide, putting in a nasocystic drain to clear this debris, but there is a limit to amount of necrosectomy that can be done endoscopically. Our own data from our patient, which shows we are talking about an endoscopic step-up approach for these patients with walled-off necrosis. You can see this. This is the data from our center. We have a huge set of patients who have undergone these interventions, and if you can see this, majority of these patients did not require any intervention beyond placement of a lumen opposing metallic stent. 75% of these patients, we just placed the metallic stents and they did absolutely well. So they did not require any necrosectomy. Obviously, these are the patients who have very minimal amount of debris, so that it just drains off spontaneously and we don't require any intervention. Now, the other 25% of the patients who did not do well with this just placement of the stent are the patients who went for subsequent interventions in the form of declogging. I'll show you what declogging is. And then patients who did not respond to declogging underwent placement of a nasocystic drain, and patients who did not do well with this underwent direct endoscopic necrosectomy. So you can see this, 75% of the patients underwent just placement of the stent, and they did extremely well, and only very small percentage of these patients underwent necrosectomy. What I mean by declogging is, once you put this lumen opposing stent like this necrosum blocks this stent, and you just declog this stent, these patients do well. And the patient does not do well with this, then we put a nasocystic drain and irrigate with hydrogen peroxide. And patients who don't do well with this, a very small percentage of these patients, we do a direct endoscopic necrosectomy, wherein we go with an endoscope into the wall of necrosis, and using basket snares, we do this debridement. So you can see this. This is the data. 75% of the patient did well with an index procedure, and patients who did not do well underwent a step-up approach, and only a very small percentage of patients required direct endoscopic necrosectomy. But if you can see this, if you follow this step-up approach, almost 96% of these patients seem to have done well. So these are patients who have wall of necrosis in good approximation to the posterior wall of the stomach or to the duodenum. Now, what happens to patients who have this wall of necrosis which is extending beyond the stomach and the duodenum? Now we have this combined modalities that have come, both the endoscopists and the interventional radiologists have come together. You place an endoscopic lumen opposing metallic stent to drain the fluid here, and in addition you have a percutaneous drain which is placed, which can be used to drain the extra the wall of necrosis which is spread beyond the stomach or the duodenum. And sometimes it is possible that we are not able to drain with this simple pigtail catheters. We can dilate these tracts and go with an endoscope through this percutaneous tract and do this debridement. So these are all the combined modalities that are used to improve the overall outcomes of these patients with wall of necrosis which extends beyond the stomach and the duodenum. So we have two modalities right now, an interventional radiology which a step-up approach, and we have an endoscopic step-up approach. So now, does this mean that interventional radiology step-up approach and an endoscopic step-up approach that is currently being practiced, are these death knell to surgery? Does it mean that there is no role for surgery in current day clinical practice? Let us look at the data that is available supporting the role of surgery or minimally invasive surgery. Now I have told you that we have this wall of necrosis, and we have this wall of necrosis which extends into the paracolic gutters, into the mediastinum or the mesentery. Now these are the patients, you can see this wall of pancreatic necrosis. These are patients who do very well with endoscopic drainage. Now we have this patients who have this extensive necrosis which extends beyond the stomach or the duodenum, and you can see this surgery has been the gold standard. We use a midline incision, and you can see we use sponge holding forceps and our fingers to do the debridement, make sure that you take out that entire debris. And sometimes it is very difficult. You can see this, these very rigid instruments are used to do this necrosectomy. This is the limitation on the endoscopy side. We don't have instruments like this, and we cannot use the finger during endoscopic interventions. We can see this, we use a lot of our hand, the finger, to take out all this necrosum from the retroperitoneum. And what we do is either we do a close continuous lavage, planned re-laparotomies or delayed closure, or we practice this open packing or re-laparotomy. The most commonest procedure that is practiced is the close continuous lavage. This is what it means, that you do this entire necrosectomy, you let out all the fluid, necrosectomy, and then you put these two drain tubes which are used to irrigate and let out this fluid in the post-operative period. Now, whenever we have this patient with colonic communication, obviously these patients require some sort of a diversion procedure in addition to the necrosectomy. Here is one such patient who initially underwent a endoscopic drainage and subsequently shown a colonic communication, did an extensive necrosectomy in addition to transection of the segment of the colon, and you can see we have done a diversion colostomy and a feeding jejunostomy in this patient. These patients subsequently did very well. Now, some of these patients who undergo lumen opposing metal stents, suppose if we had done it very early when the stomach wall doesn't get very well approximated to the wall of necrosis, it is likely that these stents are migrate into the peritoneal cavity, like happened in this patient. You can see this. This is a stent which is migrated into the peritoneal cavity. These are the patients who obviously require surgical intervention. This is the stent that is removed. Then you do a debridement and subsequently do the course continuous lavage. So what are the outcomes of different surgical open techniques that we practice? You can see this. Actually, these patients who undergo open procedures, the mortality is less than 10% in majority of the series. You have large series published from across the globe, which shows the overall mortality is about 10 to 12% in majority of the series, and the complications associated with these different open techniques also seem to be very less, in the form of pancreatic fistulae or enteric fistulae is less than about 15% in all these series. So with the advent of laparoscopic surgery, more and more of centers seem to be switching over from open surgery to laparoscopic surgery or minimally invasive surgical techniques. There has been a paradigm shift from laparotomy to minimally invasive laparoscopic techniques. Tertiary care centers with sufficient expertise are increasingly using this minimally invasive techniques, and this is documented to show and is associated with lower mortality. Now, when it comes to laparoscopy, it can be the transgastric, retrogastric, retrocolic or retroperitoneal scopic debridements can be done. All potential areas of collection can be accessed through laparoscopy. Complete removal of the sequestrum is possible, and it is augmented whenever it is not possible with pure laparoscopy. We can augment these results using a hand port. You can see this, some of these procedures, a cystogastrostomy with stomach and the wall of necrosis. This can be either a stapled anastomosis, or you can do a suture anastomosis between the stomach wall and the wall of necrosis, and you can do this necrosectomy. These are well documented procedures, and if you see literature from across the globe, this is associated with success rates almost about 90 to 100% from various studies that are reported from across the globe. Retroperitoneal scope is the other modality, minimally invasive modality. Now here the necrosis is approached by direct retroperitoneal scope, dilatation of the previous PCD, or you can go in directly. I'll show you subsequently using a trocar, and you have this trocar drainage, and you can use an operating nephroscope or a videoscope, and it can be done even in critically ill patients because there is no contamination into the peritoneal cavity in this patient. Just to show you wall of pancreatic necrosis undergoing a retroperitoneal approach, you can see this. We can using an OptiView trocar here. We have marked the wall of pancreatic necrosis using ultrasound initially, and you can see this. We are using this OptiView trocar to directly gain access into the wall of pancreatic necrosis in the window that is shown by the ultrasound or the CT. You can see this. It is something like what we put this trocars in bariatric practice. We are putting this directly into the wall of pancreatic necrosis, and once in the wall of pancreatic necrosis, you drain off all this infected fluid. Spontaneously drains off, and subsequently you can put the conventional scopes, get into the retroperitoneal wall of necrosis, and you can have additional ports that can be placed beside this original port, and you can have this rigid instrument which can be used to do debridement. The biggest advantage of this direct visualization is that we will be able to avoid some major vessels that transgress this retroperitoneum. You can see this, some of these vessels, I'll show you. These are huge vessels that are traversing the retroperitoneum. Suppose if you are doing it blindly, it is likely that these vessels get ruptured and will have torrential bleed. And you can use this blunt instruments, the suction cannulas can be used. You can see this, we are going across the vessels, around the vessels. Make sure that you don't damage these vessels, otherwise it can cause massive bleed. And then you do a thorough debridement, lavage of this, and then put a drain, 2 drains in this cavity. You can see this. This is how you do a lavage, and subsequently put 2 drains and come out, and then the patient is absolutely comfortable. You can irrigate this like what we do in course continuous lavage. We continue irrigating in the post-operative period, and these patients seem to do extremely well, and we have data from across the globe which shows that this is associated with less than 10% mortality, and the success rates almost in the tune of 90% in this select group of patients. With increasing use of endoscopy and laparoscopy, now we have this hybrid procedures which are being done in some centers. This is another procedure, minimally invasive procedure, wall of necrosis. You mark it with CT, and then you can use a direct trocar you're going from the abdominal wall, anterior wall of the stomach, posterior wall of the stomach into the wall of pancreatic necrosis, and then you let out all this infected fluid using this single trocar. So you can see this, you have wall, and you can use this conventional suction cannula going directly into the wall of necrosis. You evacuate as much as possible and subsequently withdraw this trocar slightly into the stomach, and then subsequently use this stapler to create a cystogastric anastomosis. You can see this, you can use this stapler to do a cystogastric anastomosis, and once you have created this wide cystogastric anastomosis, this is the biggest advantage of surgical anastomosis, because you can create an anastomosis of 5 to 7 centimeters compared to a 2 centimeter anastomosis that is created endoscopically. Once it is created, then you can do this debridement using this either endoscopic or laparoscopic instrument, and at the end of the procedure we just have to close the the gastric wound on the anterior wall of the stomach. And you can, if you compare the different modalities that we have, different minimally invasive techniques that we have in current day clinical practice, all of them seem to have equal success. You can see this, the complications associated are almost similar, and the efficacy of these almost seems to be same. It all depends on the type of wall of pancreatic necrosis and the clinical status of the patient. There are several issues regarding minimally invasive techniques. This is an emerging modalities, be it endoscopy or interventional radiology or laparoscopy. The data supporting minimally invasive techniques is limited. There are lack of well-designed trials because of lack of expertise and lack of widespread expertise. There are variations in techniques in different institutions, and sample size required to show significant outcome is huge, and extension to routine clinical practice has lots of limitations because of the limited expertise and limited technology in different parts of the world. So you can, as I told you, we have this wall of pancreatic necrosis and this necrosis which are extending into paracolic gutters, mediastinum, or into the mesentery. So now, as in today, the preferential techniques for wall of pancreatic necrosis should be decided based on the anatomical location of pancreatic necrosis and the extension of this wall of pancreatic necrosis into the other compartment. So you can see this, based on this extension, based on the anatomical location, current day, and based on the expertise that you have, either these patients can go for endoscopic treatment, interventional radiology treatment, a laparoscopic treatment, or a surgical modality. So these are the preferential treatment that are based on the anatomical location and based on the expertise available. But surprisingly, what happens to the compliance? Now we have guidelines, we show that these procedures can be done, but what is the compliance to these medical minimally invasive techniques? There is absolute poor compliance to this minimally invasive techniques that we practice. And the question that is repeatedly asked is open necrosectomy still obsolete? Now let us see some data, a beautiful huge data that has come from our own country, from Gangaram Hospital, to show that all these patients who underwent emergency procedures, you can say this open necrosectomy still remains one of the primary modalities to treat these patients with walled of pancreatic necrosis with extension. And we have this multi-center data that is pulled up from across the globe. You can see this, all these authors include people who are involved in interventional radiology, laparoscopy, endoscopy, and open surgery. Now we have, this is the practice pattern of 51 hospitals across 8 countries. They have shown in 1,980 patients, open necrosectomy still being practiced in 1,167 patients, minimally invasive surgery in 467, and endoscopy in 346 patients. So you can see this, in spite of the evolution of minimally invasive techniques across the globe, in spite of being shown that these modalities can be used, because of lack of expertise and because of adequate literature support, open surgery still continues to play an important role in the management of these patients with walled of pancreatic necrosis. And you can see this is again a beautiful paper from our own country, especially people not in the tertiary care, in primary care hospitals, where people do not have access to this advanced minimally invasive techniques. You can show this, these patients seem to undergo open surgery with very good results. And if you see what has happened, initially when there was initial enthusiasm about interventional radiology and endoscopic procedure, more and more of these procedures were done using this minimally invasive procedure. But with more and more literature coming in, more and more data showing in that there were poor compliance to these procedures, there is more data to show that open surgery still continues to have important role in the management of these patients with pancreatic necrosis. Now let me show you some more data to show this randomized controlled trials which are comparing endoscopic or surgical approach for infected pancreatic necrosis. We are comparing an endoscopic step-up approach versus a surgical step-up approach. Now all these endoscopic patients had good transgastric access, whereas non-endoscopic or surgical step-up patients did not have good endoscopic access. So this is obviously goes in favor of endoscopy. Patients who had an endoscopic step-up approach in good relation to the stomach seem to have done very well. And again, this is another paper which shows open transgastric debridement and internal drainage of symptomatic non-infected pancreatic necrosis. You can see this, the surgical morbidity, mortality are similar to minimally invasive techniques. And this is a beautiful paper which showed different surgical techniques: transgastric cystogastrostomy and debridement, open procedure, cystojejunectomy and debridement, and laparoscopic approach. You can see this, these procedures are tailor-made depending on the anatomical location of the wall of pancreatic necrosis. And you can see this single-stage transgastric necrosectomy is an excellent one-stage surgical option for symptomatic wall of necrosis in highly selected patients. If these patients were to be compared with endoscopic and surgery, especially patients with good approximation to the stomach, these patients seem to be doing very well. And there is a beautiful randomized trial which has come from All India Institutes of Medical Sciences, which shows that whenever we have this patient with less than 30% debris, you call them pseudocysts or you call them wall of necrosis, the endoscopic and laparoscopic techniques seem to have equal efficacy for internal drainage. So this is the randomized trial that has come from our own country, again to show that patients with less than 30% debris, good approximation to the stomach or duodenum, these patients do very well with endoscopic or laparoscopic drainage. But whenever the debris is more than 30% or the wall of pancreatic necrosis is extending beyond the stomach or the duodenum, these are the patients who would require something beyond endoscopy or transgastric intervention. And this is a beautiful meta-analysis that has come just very recently. Now it shows that there is increasing amount of evidence that is coming in. The overall certainty of evidence is moderate, though there is some benefit of endoscopy over surgery, especially in patients who have got good approximation to the stomach and duodenum. Minimally invasive surgery, minimally invasive laparoscopic procedures and open surgery also seem to have a good role. So we at our department in our institute have a pancreas board which constitutes physicians, interventional radiologists and the surgeons who decide which type of procedure patient has to undergo so that we have the least morbidity and mortality in this patient. And if you can see this, post Panther trial, when Panther trial come in, initially there was increasing number of these patients who were undergoing interventional radiology procedure, but with more and more data coming in, you can see this, more of endoscopic ultrasound. Initially we did not have endoscopic ultrasound, then we had endoscopic ultrasound evolving and endoscopic ultrasound which is stabilized. So now we have three modalities, an interventional radiology, an endoscopic ultrasound and a surgical modality. You can see this with increasing evidence. We have seen this, there is increasing number of patients who are going for primary surgery vis-a-vis compared to what was done earlier. And if you can show our own data, you can see this, patients going for primary surgery, the mortality is very, very less compared to patients who come following post-PCD. The mortality is higher basically because of the septic complications and the nutritional complication, and post-EUS the mortality seems to be very high basically because of the infectious complications and the nutritional complications that we develop because of the delayed surgical intervention that happens in this patient. And the overall mortality is about 14% in all these series. So you can see this, if you select these patients and take these patients for primary surgery, be it laparoscopy or open surgery, depending on the expertise that you have, these patients seems to do well, and we have a select group of patients which do very well with endoscopic and radiological interventions. So to conclude this, the management concepts of walled up pancreatic necrosis have evolved and standardized from conventional surgical procedure. I've shown you a lot of data as to show you how these procedures have been standardized. Surgery continues to be the standard of care because of several limitations of MIS techniques and compliance issues. Primary surgery, including laparoscopy and retroperitoneal scope, are associated with good outcomes with low morbidity and mortality. And interventional radiology or endoscopic failures require open surgery, because once you do an interventional radiology or endoscopic procedure, localization and complete necrosectomy and laparoscopy becomes difficult. You cannot localize this wall of necrosis. So for these patients who have undergone an initial interventional radiology procedure or an endoscopic procedure, if these patients were to come back for surgery, it has to be an open surgery because laparoscopy is going to be difficult. And IR endoscopic failures are associated with increased morbidity and mortality because of septic and nutritional factors, and surgeries seem to be complementing both interventional radiology and endoscopic treatment. So this is a beautiful paper which sums up the practice guidelines of the so I'll just read it with you, which shows that there are many different interventions in varying states of evolution available for treatment of pancreatic and peripancreatic necrosis. These interventions should be offered in the context of optimal intensive care and medical management, and that a multidisciplinary approach is required in a center with specialized expertise. This is absolutely very, very important. So I'll conclude and I'll show you the algorithm that we follow. This is the best thing that we have to follow. Now we have a patient with walled-off pancreatic necrosis. Now this is in good approximation to the stomach or the duodenum, and if there is less than 30% debris, these are the patients who can go for an endoscopic intervention with placement of a lumen opposing stent or a step-up endoscopic step-up approach. Now if there is more than 30% debris, these are the patients who can go for open or laparoscopic procedure, open or laparoscopic transgastric cystogastrostomy. These patients seem to do very well. Now if the walled-off necrosis is extending beyond the stomach or the duodenum, less than 30% debris, these are the patients who do very well with the interventional radiology step-up approach, or these patients can go for open or laparoscopic procedures if the expertise for interventional radiology is not available. But if the debris is more than 30% and this patient is sick and unstable, it is better that you do a pigtail catheter initially or a radiological step-up approach, and if it fails, we have to go for open surgery. If the patient is stable, you can take this patient for a radiological step-up approach, and if it fails, you can go for open surgery. But if it's stable patient, you can either go for an laparoscopic or an open procedure depending on the expertise that is available in the center. So this is absolutely clear. We should do a good cross-sectional imaging, be it be a good CT scan or an endoscopic ultrasound to assess the amount of debris. 1, assess the functional status of the patient. 2, assess the nutritional status of the patient. Make sure that these patients are suitable for any particular intervention. A beautiful editorial, a beautiful article that was published basically by an endoscopist. You can see this. This is what it means actually. Walled-off necrosis, absolutely walled off. It is like an absolute ripe mango here. Absolute walled-off necrosis in good relation to the stomach or duodenum. These are the patients who do extremely well with endoscopy, but as the necrosis extends beyond the stomach or the duodenum, it is either interventional radiology or surgical procedures that have to be done so that the overall morbidity and mortality in these patients is less. So basically walled-off pancreatic necrosis is a multidisciplinary approach basically between a HPB surgeon, an endoscopist and an interventional radiologist, but at the same time it has to be tailored to the anatomic location, comorbidities and the available expertise, but we should not underestimate the role of critical care intensivists, who plays a very important role in the entire duration of admission of these patients. So critical care intensivist becomes very, very important. So it's a multidisciplinary approach between the HPB surgeon, endoscopist, interventional radiologist and a critical care intensivist, and a beautiful article which says, together we stand, divided we fall. It has to be a multidisciplinary approach to manage this patient with this walled-off pancreatic necrosis. So what about the future? I made this cartoon for my department. This is what I expect it can happen. This could be the least morbid procedure. We have this robotic capsule. We should be going in, make an incision between the stomach wall and the wall of necrosis. Again, this should be suitable only for limited patient. Do a necrosectomy, then use this zipper. We used to use this, do this zipper laparoscopy before. Remember, some of my own colleagues, we used to do this. Used to zip this open and come back and then open this and then do necrosectomy once again and close this zip. And this is what I expect to happen in future, but till that time, the algorithm that I showed you should be the pattern in which we have to follow these patients, treat these patients in the intensive care, and depending on the expertise that is available and depending on the technology that we have available, we have to tailor make these interventions based on the anatomical location and the comorbidities of these patients. Thank you very much once again for the patient hearing.
Hello, sir. Thank you very much, Dr. G V Rao, sir. That was an excellent lecture. Overall, you gave overview of a minimal approach for the pancreatic necrosis and walled off necrosis. And I saw a lot of slides and a lot of literature, which is again goes in favor of percutaneous or endoscopic intervention in necrotizing pancreatitis. So that's an excellent lecture, sir. And you really enlightened us. We learned many things from you, sir. There's one question from Dr. Akshay. He is asking, poor compliance is not understood. I mean, there's poor compliance.
Yeah, absolutely. Veerappa, what you said is actually what Dr. Akshay was asking is very right. See, we have this lot of guidelines, lot of evidence that has come in favor of intervention radiology, endoscopy, minimally invasive laparoscopic surgery, and open surgery. Unfortunately, what is happening is actually, though we have these guidelines to show this wall of necrosis is best drained by this method, it is not necessary that that expertise is available everywhere. So what happens is, though we have guidelines that have been set up, though we have evidence to show that this is the best practice for this sort of necrosis, but unfortunately, because of lack of expertise, a lot of technology, that particular this thing is not adapted to. That's what we mean by compliance. So in a peripheral center, like if you say, actually, I've shown you the data from our own country, in a peripheral district hospital, suppose the patient comes, obviously, I mean, you cannot try any of the radiological procedures or the endoscopic procedures. Obviously, this patient goes directly for surgery because of a lot of limitations. This is what I mean to say. When I mean by compliance, I mean that whatever is in the literature, whatever is evidence proved, it is not that we are 100% translating into clinical practice.
But the basic principles, wherever is in a periphery or is in a center, the basic principles are there's no early intervention for a pancreatic necrosis.
Absolutely.
So that is most important. Like in previously, we used to go in early and we have burnt our fingers. There was bleeding, there are some problems, fistulas. Hence, the later and the least most important. Yes. So there's another question from, again, Akshay. What is your approach for pancreatic pseudocyst which requires drainage, or IR, or endoscopy, or minimal invasive surgery?
Yeah, pancreatic pseudocyst, which is in good approximation to the stomach. Most of the pancreatic pseudocyst you're talking about in good approximation to the stomach or duodenum. I've shown you the literature, including a randomized trial which has come from All India Institute of Medical Sciences, which has shown that be it be endoscopic drainage or laparoscopic drainage, both of them are equally effective. So depending on the expertise, you can do the thing. Or it has also been shown that open surgery, open transgastric cystogastroscopy is also effective actually in all this. So if you have facilities, actually endoscopic option is the first option because hardly any debris, pure endoscopic cystogastroscopy is best. Interventional radiology is no for a pseudocyst which is in good approximation to the stomach and duodenum. Suppose if you don't have endoscopic expertise, I think then laparoscopic or open surgery is the best option.
I think the importance here is symptomatic pseudocyst. So if the patient has any symptoms, definitely needs an intervention. Asymptomatic pseudopancreatitis, a smaller size, they not need any intervention.
Actually, and the other thing is actually also right, Birappa, actually, initially we used to say that 6 weeks, 6 centimeters, the full of 6, actually, that does not hold good anymore in current day clinical practice. As long as the patient is asymptomatic, we just wait and watch for these patients.
Yes. I think that's most important. So symptomatic pseudocyst needs an intervention, not necessarily be an asymptomatic. And suppose the symptomatic pseudocyst in the tail of the pancreas, probably that's what he mean to, he would like to know. So in those cases, maybe if the surgeon is an expert, he can do an assist enterostomy.
Yeah, absolutely.
Or open surgery.
I think doing an interventional radiology pigtail catheter for a pseudocyst, I don't think it is advisable actually.
Yes, sir. Because chance of pancreatic fistula is there. So hence we may not agree. So there's one other question from Devansh. You would like to know what markers would advise for prognostic markers for walled-off pancreatic necrosis. So if there is an infection, we have a lot of markers like C-reactive proteins, procalcitonin. Another from Bhupendra Mehra question. Congratulations, sir. Very nice presentation. When we can do a retroperitoneal necrosectomy without peritoneal contamination? What is need of laparoscopy or transgastric necrosectomy? Please explain.
This is actually retroperitoneal scopic necrosectomy. Absolutely. See, suppose if it is pointing onto one of the flanks actually, and if you have a good window, if your interventional radiologists say that they can have a good window, and they're obviously pointing into the flank somewhere, actually, these are the patients who do extremely well. I mean, of course, if it's a gallstone pancreatitis requiring a cholecystectomy, it might require a second stage. But otherwise, what happens is these are the ones which are absolutely drained well. We can have either, it is something like the Panther Trial, like either put in a pigtail catheter, then subsequently do a video-assisted necrosectomy, or suppose we have good trocars right now, we are able to go in with the trocars directly and do a necrosectomy. These are all the retroperitoneal scopic, but we should have a very clear window and the radiologist should be able to mark it very clearly to us. The biggest advantage of this is actually even if you have more necrosum, we should be able to get it out through this small incision that we can make.
Yeah, sometimes there will be some pointing the necrosis in the retroperitoneal, which will be connecting it to the lesser sac. In those cases, probably in a nick and then pass the retroperitoneal scopy and then take out all the necrosum. Yeah. And if the necrosum is very close to the stomach, as you mentioned, transgastric endoscopic necrosectomy. There's another question from Narayan Kabadi. Management of walled-off necrosis with pseudoaneurysm with bleed, how to manage? So, shall I answer, sir? Yeah. So, management of walled-off necrosis, sterile walled-off necrosis doesn't need any treatment. So, infected walled-off necrosis definitely needs an intervention, whatever kind of intervention, say endoscopic, laparoscopic, or percutaneous. If there is a bleed, pseudoaneurysm, and if the patient has usually these people will develop an hypovolemia or shock. So, these are the patients you should suspect a pseudoaneurysm and needs an angiogram and better to embolize if you identify the pseudoaneurysm. But if it is bleeding from the smaller vessels, then it's a problem. It's very difficult to identify the aneurysm sometimes. If you identify the aneurysm, it's better to embolize. If not, if the bleeding is continuous and the patient is hemodynamic instability, I think it's better to go in, evacuate and arrest the bleeding.
Yeah, absolutely. So get the thing, pack the thing, actually pack it up completely, make sure the patient is stabilized and refer it to a center where it can be tackled.
Yes, sir. Yes. There is another question from Dr. Sheikh. Pancreas is severe pain and amylase lipase is high condition, not stable. So give your surgery and conservative management. So I did not understand the question. Probably unstable patient where the lipase and amylase levels are very high and what to do. That's what I think. So if the patient is unstable, it means that probably he has a severe acute pancreatitis wherein he has an organ failure. It could be a single organ failure or multiple organ failure. So the most important, it's not the levels of amylase or lipase which is most important. And amylase is non-specific. Lipase also, sometimes it may be raised in other conditions. So even if this lipase levels are more than 600 international units, it only confirms that the patient has a pancreatitis. So probably what I understand from your question is severe acute pancreatitis and the conservative management. Yes, we need to identify these patients. We need to put these patients in intensive care management. As you said, sir, the important hemodynamics of the patient, volume resuscitation in terms of linger lactate or in a normal saline, crystallites, give them and then manage, check the urine output, check the blood pressure, and check the CVP, and accordingly manage in the intensive care units. I think that's probably that way the question. It's not the level of amylase or lipase which matters here. It is an organ failure which is most important to manage these patients in intensive care unit.
Absolutely, what you said is absolutely right, Dr. Veerappa.
So there are no more questions. So I have one small doubt. So you have mentioned endoscopic interventions and successful in 75% of the patients. So I just would like to know in 25% of the patient, what was any problem, whether the necrosis was quite away from the...
This is what happens actually. Veerappa, this is what actually I keep debating with my medical gastroenterologist. What happened was the endoscopic ultrasound came in a big way, and all the CT pseudocysts have become endoscopic ultrasound wall of necrosis, because endoscopic ultrasound detects debris very well.
Yes,
so,
yes.
So most of the moment you see debris, it is called as wall of necrosis.
Yes, sir.
So unfortunately, what happens is, I personally feel most of these things are CT pseudocysts with minimal amount of debris.
Yeah.
So when we put this stent, obviously majority of them are with minimal debris, so they do extremely well. You don't have to do anything else.
Yes, sir.
But
yes.
other 25% of the patients, who are the patient who have more than 30% of debris, which is not completely removable. So that's what I showed. What it means, sometimes the lumen opposing stent gets blocked with the necrosum, and you have to remove the thing, or you have to put a nasocystic drain, irrigate the cavity. And very rarely, it's very small percentage, about 5% or between 5 to 10% are the one which requires direct endoscopic necrosectomy, wherein you go directly into the retroperitoneum. And if you have this, has to be done only with expertise, please. And then you start doing the necrosectomy. But again, this is possible only in walled up necrosis that have good approximation to the stomach or duodenum. I think we all know when we are doing open necrosectomy itself, it is so difficult to use a blunt finger and a sponge holder.
Yes, sir. Yes. Yeah.
And get into the nooks and corners. This is very, very difficult endoscopically, or sometimes even laparoscopically, I feel is difficult.
Yes, sir. Yes, I agree, sir.
So the majority of the ones that are on the endoscopic series that are being published, most of them, yes, both of them are amenable to simple placement of stent, but a small percentage of them only seem to require a necrosectomy.
There's one more question from Devan Sarora. Would you advise any antibiotic for continuous irrigation post-surgery through the drains?
No, this is actually closed lavage system that we do. We don't use any antibiotics actually. Normal saline lavage is more than sufficient actually.
Yeah, it's not advised to use any antibiotics through the drains. It's not necessary. We also do not advise that. Another question is initial stage of pancreatitis cholecystectomy can be performed. That's from Dr. Paria from Kanpur.
Yeah, I think Dr. Veerappa can take that.
Yeah, cholecystectomy, if it's in a mild pancreatitis, well, you can do a cholecystectomy in the index admission. If the patient has a severe pancreatitis, gallstone-induced severe necrotizing pancreatitis, we need to wait for at least months, to settle the necrosis and acute fluid collections. So then go for a cholecystectomy at a later date. So mild pancreatitis, yes, in the same admission, whereas severe pancreatitis, once the severe pancreatitis settles, then we can plan for a cholecystectomy. Sir, in this kind of patients, is an MRCP is a mandatory?
No, yeah, this is a very good question actually. Now in gallstone pancreatitis, whenever we are suspecting gallstone pancreatitis, yes, based on the thing, actually MRCP or endoscopic ultrasound seems to be having a slight edge over MRCP to pick up sludge in the bile duct.
Yes.
So I personally feel actually if we have facility, we should have an endoscopic ultrasound, and if the patient has cholangitis, ascending jaundice, severe pain, we intervene. These are the clear-cut indications. But between MRCP and endoscopic ultrasound, I am slightly more in favor of endoscopic ultrasound because it picks up that sludge which is responsible for gastropancreatitis.
Yeah, and another advantage of endo-US is in elderly patients with comorbidities, you can as well do an endoscopic sphincterotomy.
Not about the same time actually. So it's a one-time, one-stage procedure. You can club both the things. Absolutely.
Yes, sir. So, no more questions. And I just would like to know, sir, suppose the patient has completely improved with conservative management, but after 6 weeks, we have seen some patients after 6 weeks or 7 weeks coming back with again pain, the severe pain in the abdomen, not exactly thriving. They don't feel like having a food. They say loss of appetite, and we do investigation. Sometimes there may be some minimal collections. So this kind of patients we do get sometimes after conservative management. Probably a disconnected duct or some infected collection. I think we need to look. So I just would like to know your opinion on this, sir.
Yeah, these are absolutely right. Actually, all these walled-off necrosis patients whom we are following, I mean, suppose they come back with severe pain, it is either because of some bleed into the walled-off necrosis, or it could be some infection, again, superadded infection, or as you rightly said, a disconnect gut syndrome that is responsible for sudden surge and the increase in the size, or it is causing some sort of pressure effect on the stomach and duodenum, which causes the patient experiences decreased appetite and nausea. These are the patients who require, again, good cross-sectional imaging and maybe an intervention depending on the type of walled-off necrosis there.
Yes, sir. There's a question from Dheeraj Kumar. Why don't gastric contents go into the cyst after doing a cystogastostomy?
Very good. See, actually, if you look at this, this is what, again, this is the debate that we have with the medical gastroenterologists. See, when surgical, actually, I think Dr. Birappa will agree with me. When you do a surgical cystogastostomy, the peristaltic wave which goes from the fundus towards the pylorus, if you see the anatomy of the stomach, when the contractions go from the cardia on to the pyloric side, it makes sure that the defect, whatever rent that you make, it closes. It does not.
Yes.
This is the basis. Unlike what happens when they put a stent, there is every likelihood that the food can go into the walled-off necrosis. The biggest advantage of surgical anastomosis is that because of peristalsis, it automatically closes and it does not allow the gastric content to go onto the retroperitoneal cavity.
And also in the surgery, once we drain completely and do a cystogastostomy, the cavity collapses. So automatically it's the anastomosis also closes.
Yeah, absolutely.
Yeah. There's another question. Sir, you talked about closed drain system. How to monitor them? Ideally, ideal day to remove them. So that is the question. We actually monitor. We keep a drain. Suppose following in a surgical open necrosectomy, we keep a drain in the lesser sac, one on either side, and irrigate first 48 hours with a ringer lactate or normal saline. So most of the practical problems in this, the muck, whatever which comes out, it blocks the drains. So we need to really flush sometimes and then or irrigate the drains. And if it's whatever the fluid is giving, it's coming out completely with the debris, then we need to wait for some time till the contents are clear. The content, it's very difficult to say like you remove after 1 week or remove after 2 weeks. It's not that. So we need to see that the output is clear and whatever you give, the content is coming out is clear. There's not much of a debris and of course overall clinical improvement. So and there's nothing.
Watch on the pancreatic amylase, the fluid amylase levels.
Yes, sir. Fluid amylase level also is most important. When it's less than 50 ml, and then we might remove the drains. This question, some people complain the severe pain in the left iliac part. Is it a sign of pancreatitis?
Actually, this could be, see, some of this could be because of the pancreatitis that is extending in the left paracolic gutter, because that is the path of least resistance actually. What is said is absolutely right. Most of the, if you analyze 100 patients with severe acute pancreatitis, you have majority of them which is all of the stomach or duodenum, and some of them, and the next commonest thing is that these patients have this extension into the left paracolic gutter actually.
Yes, sir.
And it is likely that because of these, the patient could be complaining of pain in the left iliacus.
Yeah. There's another question: how to manage recurrent pancreatitis? So probably you mean to say, probably is asking for another gallstone pancreatitis or a pancreatitis who had complete recovery and is getting recurrent pancreatitis. So probably it's because of one is cholecystectomy is not done in a patient who had a gallstone pancreatitis. Number one. Number two, recurrent pancreatitis could be again disconnected duct. So the duct is disconnected and the distal part of the duct is dilated. That's the reason why he's getting a recurrent pancreatitis. Number three, it could be an autoimmune pancreatitis, which is not treated completely. So I feel there are three I would like to know from you, sir.
Yeah, actually, what you said, recurrent pancreatitis post-op is absolutely right. What Dr. Birappa said is basically because of the disconnected duct, the distal part dilates, and then you have this recurrent pancreatitis. But if you're talking about recurrent acute pancreatitis, de novo recurrent acute pancreatitis, it could be because of various things. You all know the alcohol, gas, drugs, some genetic factors, some toxic chemicals, anatomical things like pancreas division could be responsible. And there are some genetic mutations that are responsible. And of late now, if you ask our clinical gastroenterologists to say, they're now depending on more and more of endoscopic ultrasound to say that there is some sort of early chronic pancreatitis that they're picking up, which seem to be responsible for recurrent pancreatitis, or we call that a small duct disease and early chronic pancreatitis. So we have to rule out all this sequentially. Majority of the time, it is basically because of alcohol and gallstones. But if these two are ruled out, then obviously we'll have to check for the parathyroid hormone. You'll have to check for the lipid profile. You'll have to check for the genetic profile. Do an MRCP to rule out pancreas division. All these have to be ruled out, and all these are negative. Then you do the genetic testing, and obviously endoscopic ultrasound part forms part and parcel of the workup to rule out any early chronic pancreatitis.
Yes. So there are no more questions, sir. I have a little one more doubt, sir. Initially you mentioned, is there an indication for a surgery in the early period, say within 1 week? So exceptional. We don't advise surgery in the first week of surgery at all. But are there any exceptions where we can definitely these patients might require a surgery?
Yeah, actually, very right, Birappa. Actually, there is a small percentage of patients whom we don't want to intervene less than 4 weeks, but the patient clinical condition, the patient is deteriorating and he's got some sort of an abdominal compartment syndrome.
Yes.
The patient is deteriorating because of this. I think this, obviously there is increased morbidity and mortality, but a very small percentage of patients, even with sterile necrosis, may require intervention if they are unstable and they're deteriorating. These are the only patients who require.
Yeah, I think abdominal compartmental syndrome initially 48 hours. That's why goal-directed fluid therapy is very important. Some of the people, some of the surgeons, junior surgeons, they aggressively treat with the fluids. So it might sometimes harmful for the patient because the edema of the bowel, because third space loss, they may have an abdominal compartmental syndrome, which can be measured by measuring the urinary bladder pressures. If it is more than 20 millimeters of mercury, probably these are the patients needs some sort of an intervention like percutaneous drainage of the ascitic fluid, or they may have some fluid effusion. Sometimes we need to drain them. So, or if the patient has some ARDS picture, we need to intervene. So many people ask me, sir, is there a role of an antibiotic as a prophylactic in a case of a severe pancreatitis and there's a necrosis?
No, absolutely. No role for antibacterials or antifungals in the initial stage unless and until we have documented evidence of infection. Initially people used to do this FNA to see whether there's infection or not, but this is not practice in the current day clinical practice. We don't do this. I think the only thing we go by clinical condition and also by the cross-sectional image. If these two show that there is indication for infection, these are the patients who require antibiotics. Otherwise, there is no role for antibiotic. But again, the same thing what we're talking about, compliance, we're talking about, though we keep talking about all this, but majority of the patient, the moment you see the patient, actually they started with antibiotics.
Yeah, I think, sir, one important I need to convey to junior colleagues is please do not give an antibiotic. So the moment pancreatitis case has seen, junior surgeons, they start carbapenems, and they give for a 2 weeks, 3 weeks. It's not necessary. Much literature shows this, shown that there's not much of a benefit from a prophylactic antibiotic. As you rightly said, sir, prophylactic antifungal also has no role which is not shown. So hence, there's no need for an antibiotic. So no more questions, I think, sir. Ms. Bharat?
So I should personally thank for
Yes.
came out. Thank you so much, Dr. Birappa, for giving this time. Thank you so much.
No, so it's my pleasure, sir. Always. We'd like to learn many things from AIG, sir.
Thanks to the entire executive of ASI, Dr. Shivram in particular, who is being after us. Thank you so much, Dr. Shivram, the entire executive committee of ASI. We are thankful to the both of us. On behalf of both of us, I say my sincere thanks to the entire executive of the ASI for giving us this opportunity to share our views with the surgeons across the country.
Thank you, sir. I thank ASI and thank you, Dr. G V Rao, sir, for giving me the opportunity to chair this session. And I thank Bharat and entire his team for excellently coordinating with us. Thank you very much, sir.